So thank you for coming on this Thursday night. I'm going to talk about Intacs and crosslinking, but I didn't want to just talk about those two things without putting it in the context of keratoconus. By the way, nice to see some people that I haven't seen in a long time. Hello. So hope things are going well. All right, so keratoconus treatment update. So keratoconus, just the definition, it's a progressive eye disease in which the normally mostly round cornea thins and develops an area of irregular astigmatism. Irregular astigmatism comes in many different forms. Irregular astigmatism is when there's a bulge in the cornea and it's just not smoothly or oval shaped. The incidence in the U.S. of keratoconus is around 1 out of every 2,000 individuals. So it's not super common, but we'll all see this every month. I'll see it more than that, but you guys will still see it probably every month. Why is this a problem? If the keratoconus progresses far enough, it results in irregular astigmatism. Irregular astigmatism is not correctable with glasses or regular soft contact lenses. There's basically a bulge in the cornea, and that just doesn't take care of it. How is the diagnosis made? How do we find out somebody has keratoconus? I would say almost always the diagnosis is made with corneal topography. That's really what you need to know a person has keratoconus. But most commonly, we order that test for a reason. And the reasons that I listed off here are, one, patient's visual acuity is not normal, and with the refraction, the visual acuity is still not normal, and the eye exam appears normal in other ways. So you think, maybe there's some irregular astigmatism here. Option two, you're doing the refractions, you notice the patient has increasing astigmatism from year to year, and you start worrying about this as a problem. Number three, patient has no symptoms, but they're interested in refractive surgery, and we're going to screen people for keratoconus by doing topography. And option number four, patient has a family member with keratoconus, and it runs in families a little bit, so sometimes we'll order the test for that reason. So the diagnosis is based on topographic appearance, so the way the topographic map looks. In our office, that's a pentacam. In other offices, it might be a different brand of machine. But it's basically a map of the anterior surface of the cornea. The diagnostic criteria are more guidelines than rules. So I have written up here numbers that would make somebody a suspect and numbers that would make somebody have the diagnosis of keratoconus. But you can look at somebody's cornea and look at their numbers, and they don't meet the numbers, but the way the topography looks, you would say, yes, this is keratoconus. You might even look at numbers that are worse than these and say, well, but for whatever reason, it's not keratoconus. So it's not like it's not a rule. It's more like the speed limit. All right, so this is just a picture of a normal topography from a pentacam, and you can have some asymmetry between the top and the bottom and the numbers on the top and the bottom, but it's a pretty symmetrical pattern. The cornea thickness, in this case, is average. Average is 545. So this is a normal topography. And then this is a pretty typical keratoconus topography where the red here is elevation and the cornea is steeper. There's a bulge down here at the bottom of the cornea. And the cornea is thinner. This cornea is not super thin, 5/16, but it's thinner than average. And a contact lens, a soft contact, or a pair of glasses just isn't going to correct this bulge. That bulge is still going to be there. And so something different needs to be done to take care of this problem. Risk factors for keratoconus, younger age, it's more of a risk factor for progression. The younger you are, the more flexible everything is, the more flexible your connective tissue in your cornea is, and the more likely you are to progress. Family history of keratoconus, chronic eye rubbing, especially allergic chronic eye rubbing or really aggressive eye rubbing, chronic eye surface inflammation, allergies, and blepharitis. And then, unfortunately, refractive surgery is a risk factor because it thins the cornea. So keratoconus treatments and decision making, I sort of divided this discussion into 6 different treatments, and I ask 6 questions basically to help you decide on whether or not a person needs each of the 6 treatments. So in the end, we'll get to Intacs and crosslinking, but we're going to start with some other questions. So question number 1, is the patient stable? Are they getting worse or not? And you can determine that based on both their vision, if their refraction's getting worse, if their acuity on the chart's getting worse, and their topography. Does their topography look worse? Is it more steep or more thin? Question number 2, does the patient suffer from allergies, blepharitis, or some other condition that causes eye rubbing? Simple yes or no question. If they do, and they might not offer that, you might have to ask about it, but if they do suffer for something like that, well, we'll get to this, but we should do something about it. Question 3, does the patient see normally with glasses or soft contact lenses? Some patients have this disease, but it's such a mild version that their vision's still normal with regular glasses. That's obviously good, much better than not seeing normally with regular glasses. Question number 4, can the patient be fit in a rigid gas permeable contact lens or a scleral contact lens? Some people aren't candidates for that. Question number 5, is a patient a candidate for Intacs? And we'll go through that a little bit farther along. And number 6, have we given all available treatments a fair chance to work before we talk about a penetrating keratoplasty, which that is full thickness cornea transplant. So we really want to make sure we don't skip over any of these first options before we move on to surgical correction. Okay. So each question is kind of helping me decide on a different treatment. And each treatment has a different purpose. So each patient needs to be assessed for which treatments will benefit them, if any, and which ones won't help them. So number 1, we want to treat causes of eye rubbing, primarily allergies and blepharitis. Those are by far your 2 main causes of itchy eyes. A lot of allergy medication out there. It's not 100% effective. Treatments for blepharitis, again, not 100% effective, but you want to address these things. Intacs, crosslinking, rigid gas permeable or scleral contact lenses, penetrating keratoplasty. And then the last option is observation. Sometimes you don't need to do anything at all. Okay, so one at a time with the question. So question number 1, is the patient stable? So the younger the patient is, the less likely they are to be stable. The more likely they are for things to keep getting worse. Kind of what I was taught in school is by the time you're 40 years old, your keratoconus isn't really changing. That's not exactly true. There are definitely people in their 40s and 50s and 60s that will continue to get worse. So we do need to watch older people. But you really need to be concerned if you have a teenager or somebody in their 20s with keratoconus, because there's a very, very high chance that 1 or 2 years later, they're going to be worse. It can take a few years to establish that the patient's topography is progressing, and a lot of times you have historical data. The patient didn't need glasses, and now they need glasses, and now their refraction is stronger. If you wait to suspect the problem and then do the topography, and then you know that you have the problem, and then you want to see that the topography is getting worse, and so you have to wait a year or 2, the person could have worse vision by then. So waiting to have topographic proof that things are getting worse can be a problem for the patient's vision. Unfortunately, some insurance companies are going to want proof on the topography that things are getting worse. The treatment for instability is crosslinking. So if somebody's getting worse and you have some evidence that they're getting worse, you're thinking about cornea crosslinking as a treatment to stop the person from getting worse. Any questions about this so far? Question number 2. Does the patient suffer from allergies, blepharitis, or some other condition that causes eye rubbing? If the patient has one of these, treat it. So pretty simple. I think the most controversial thing that I'll say about this is normally we try not to treat people with allergies and blepharitis with chronic long-term steroids because they can have some side effect. But if a person really can't be controlled without steroids, they're better off taking a mild steroid like fluoromethalone, fairly long-term, as long as they're being monitored, than having them rub their eyes, wreck their cornea, and end up needing a full-thickness cornea transplant, which will result in them being on chronic long-term steroids that are even stronger and have more side effects anyways. So while we like to not use chronic steroids, this is a case where sometimes they're needed. Question number 3. Can the patient see normally with glasses or soft contact lenses? So depending on how bad the keratoconus is, how bad this bulge is, some people see normally with glasses or soft contact lenses. That's great. That's what we want. If everything would just stay there, then you're basically like a regular person with a regular life. That's what we want. We do need to make sure that somebody that is in that category is stable so that they won't progress and no longer have the option of glasses or soft contact lenses. And if they look like they're progressing, you should go back one step and think about cross-linking this person. In my opinion, we're going to talk about Intacs later, but in my opinion, there's not much of a role for Intacs in these patients, in patients that can see normally with glasses or soft contact lenses. Intacs can improve uncorrected visual acuity, but their main role is to treat irregular astigmatism and get patients back to the point where they can see normally with glasses or soft contact lenses, if that's even possible. So you guys probably all know this, but I just want to take an aside and talk about why soft contact doesn't work, but a rigid gas permeable or scleral contact lens does work. And I think of it as like if I had this chair here in the front and I threw a sheet over the chair, it would still look like a chair. And if I have a soft contact that's a soft piece of plastic and I put it on a cornea that has an irregular bulge in it, it's still going to have an irregular bulge in it and the person's still going to be out of focus. Whereas if I put a hard plastic dome over the chair, you can't tell what's underneath the dome. It doesn't look like a chair anymore. A hard contact's the same idea. It's a hard piece of plastic. It has a normal shape on the front. Fluid fills in between the contact back surface and the surface of the patient's cornea, so it sort of masks the bulge. Another good example of this would be like if you went to a lake and you looked at the top of the lake, you can't tell what's on the bottom of the lake because the fluid fills in the space there. And so that's what a hard contact does. Unlike a lake, it gives you a perfectly smooth front surface. So people with more advanced keratoconus are going to see better with a hard contact lens or a scleral contact lens. It's harder to fit, it's more work, it's more difficult potentially to put in and take out than a soft contact lens for some people. So if they could wear just a regular soft contact lens, that would be great. And getting a person some improvement so they can get back to regular contacts and glasses is a nice thing. So anyways, I've probably beaten this to death. Any questions about question number 3? All right. So question number 4, can an RGP or scleral contact lens be fit? So if this can be fit, it's going to give the patient the best vision. It corrects all of the astigmatism. So some people are happy with things being 95% corrected, and that's great. If they're happy, they don't have to go to this step. But in the end, a scleral lens or a RGP contact lens is going to give basically anyone better vision than glasses or regular contact lenses because it corrects all of the astigmatism. In somebody that can be fit in one of these and sees well, we would think about Intacs to improve the cornea shape and maybe make the fit easier and maybe allow the person to see well in glasses or soft contacts too. It depends on how far away they are from that being realistic. But if an RGP contact lens or scleral lens cannot be fit, then again, we're thinking, can we use Intacs or crosslinking to attempt to improve the patient's cornea shape and get them good enough so that they can be fit in a contact lens. Ultimately, if a person can't see well with a rigid gas permeable or scleral contact lens or glasses or soft contact lenses, and we do Intacs and that doesn't change their shape well enough for them to see well, these are the people that have done everything they can do and none of it's worked and they're heading for a full thickness cornea transplant. All right. Question number 5, is the patient a good candidate for Intacs? So Intacs are approved on the basis of a compassionate use exemption. Intacs are little plastic rings. We're going to see pictures of them a little bit later on. They're little plastic rings. They're implanted in the cornea. They were initially invented as an alternative to LASIK, a reversible technology to correct nearsightedness. But they could only correct small to medium amounts of nearsightedness, and so LASIK won, and everybody prefers LASIK for refractive surgery at this point. Intacs, people don't use them for that. So they're not officially approved for this condition. The government has said you can use them on a compassionate use basis, on a case-by-case basis, which means behind the scenes, the patient doesn't have to worry about this. but we have to do a bunch of extra paperwork with something called an IRB, an Institutional Review Board, to show that it's ethical to use this treatment in patients. But it's very, very standard practice now for keratoconus. The patient's topography needs to be analyzed by the company that makes the Intacs, Cornea to determine if they would be helped by the Intacs or not, and then it has to be approved by the Institutional Review Board. And then you still have to have 450 microns of corneal thickness where the Intacs go. Really the central cornea should be 58 or less in order to safely implant the Intact and not have it be too shallow or too deep. So you have to have a certain thickness there. And not everybody has that much thickness that has keratoconus. Okay, and question 6. Have we given everything available a fair chance to work before we talk about a penetrating keratoplasty? Penetrating keratoplasty is a last resort. It is a good treatment. I don't want to say that it's not a good treatment. I have a fair number of patients that have had full-thickness cornea transplants and are doing great, and they had severe problems before, and it is a good treatment. Keratoconus is actually the best reason to do a full-thickness cornea transplant. It has the highest success rate of any reason that we would do a full-thickness cornea transplant. But really, we are trading one disease, keratoconus, for another disease, the disease of having had a cornea transplant that needs ongoing follow-up and care. You can have rejection, you need to take eye drops. And the patient that I really try to avoid doing a cornea transplant on is the patient that can see well with a contact lens, but just doesn't feel like dealing with a contact lens. Because after a cornea transplant, usually the best vision is with a rigid gas permeable or scleral contact lens. And this is the only color I have in the whole thing, the capital D for disappointed. If somebody just doesn't feel like dealing with a contact lens and they decide to have a cornea transplant to avoid it, they're going to be disappointed a year or two later when they find out for their best vision they need a contact lens. Quite often somebody that can't be fit in a contact lens can be fit in a contact lens after they have a cornea transplant. Their cornea has a much more normal shape and it works much, much better. But for the people that are just like, I don't want to mess with that, I'm afraid to put something in my eye, they're going to be disappointed. So that's caution to myself. Okay. Any questions so far about that before I move on to some little movies about Intacs and keratoconus? Or crosslinking. Okay. All right. So part 2. So cornea crosslinking is an FDA-approved treatment now. It has a long track record of safety and efficacy. It's been around for years and years and years outside of the United States and was done in the United States in clinical trials for years. It has a long track record of safety and efficacy, and it's done to halt the progression of keratoconus. And in many cases, it partially reverses keratoconus. If the patient is not progressing, if they're not getting worse, there's probably not a role for this treatment. It's basically to lock things in place. It can improve things a little bit, but if somebody's not getting worse, it's not clear that they're going to get better when you do the treatment. Currently, the person must have a cornea thickness of 400 microns to avoid damage from the ultraviolet light to the corneal endothelium, so the inside layer of their cornea. There's some ways around that. You can get a person's cornea to swell by giving it hypoosmolar drops, and you can also put a contact lens on the eye so that that'll absorb some of the UV light. You just can't use a contact lens that has a specific UV filter because then that'll absorb all of the UV light and then the cross-linking won't work. So you have to be careful about which contact lens you use. So some criteria. How does this work? So the cornea is made up of collagen molecules. The collagen molecules are lined up straight with one another in order to keep the cornea clear. If they were all jumbled in various random directions, the cornea wouldn't be clear. It'd be like your sclera, white and not transparent. So over time, these collagen molecules gradually form chemical bonds between them, and they become more stiff over time. And this is something that just naturally happens through life. So this is just trying to show, as an illustration, the blue molecules being the collagen and the red lines being chemical bonds between them. So the cross-linking procedure increases the number of bonds, making the cornea stronger. So it just creates these bonds that we're going to form naturally with time, all at once. The natural formation of these bonds over time, that's why people's keratoconus, for most people, stops getting worse. And you're speeding this up. So what are the results of cross-linking? There's many different studies following several different protocols. So the gold standard protocol is something that's called the Dresden protocol, which includes epithelial removal, so an abrasion on the front surface of the eye, 7 millimeters in size, and then the application of riboflavin, which is vitamin B drops, 0.1% for 30 minutes. So we put a drop in the eye every 2 minutes and let that soak in, and you just keep repeating it. So it's basically 16 drops. And then the application of ultraviolet light at a certain power for an additional 30 minutes. And while you're doing that, you're putting more riboflavin drops in, so there's plenty of riboflavin there. Basically, the riboflavin is making the chemical bond. It's activated by the ultraviolet light. So this amount of vitamin, an amount of ultraviolet light, and time is effective in stabilizing the best corrected visual acuity in 96% of patients after 3 years of treatment. And if you look at the steepest keratometry readings in the average patient, at 1 year it's improved by 2.29 diopters, which is pretty good. I say it's to stabilize, but there's actually some improvement in their shape. And then that actually improves at 2 years to 3.27 and at 3 years to 4.3. So it's not an instantaneous effect. There is an effect right away, but there's an ongoing improvement in the shape of people's corneas. So the Dresden protocol does have some downsides. The treatment takes an hour to put in the drops and to do the light. And there is a corneal abrasion on the surface of the eye, and that gives a small risk of an infection or a scar. And corneal abrasions are uncomfortable. The upsides to the Dresden protocol is, at this time, there's no other protocol for doing things that has been shown to be as effective in stabilizing the disease process. And this protocol was the one that was approved by the FDA. So while you can enroll in a research study, still in the United States, to have a different treatment protocol, if you want regular insurance coverage, which is helpful because medical treatments can be expensive, it needs to be done with this protocol. The device that you can purchase to do the treatment in the United States is basically only programmed to do one treatment, and it's the treatment with the epithelium off. So that's a big advantage. Let me just talk about that a little bit more. So the alternative protocols are basically to try to give a higher concentration of riboflavin, trying to get it through the cornea without having to give the patient an abrasion. The limitation is the medication doesn't absorb as well or as deeply, and then the epithelium absorbs a lot of the ultraviolet light, so you don't get the ultraviolet light to penetrate as deeply. So you try to overcome that by cranking the light up, which can cause some damage to the endothelium, so you can't crank the light up too far. And there's various names for these various studies, and they do a good job, but they don't stabilize as high of a percentage of patients. And then the other side of things is just people being in a hurry, and they don't want to have to sit there for half an hour with the light. So they're like, well, can we give the whole dose of light in 2 minutes if we just crank up the intensity of the light? And the problem, again, is if you make the light too intense, you can injure the inside of the eye, but you just don't seem to get as good of a chemical bond formation. Going back in time, when people came up with the Dresden protocol, they looked at how fast these chemical bonds could form and how long they felt it would take to make enough chemical bonds to stabilize the cornea. And so it works to try to speed it up, but it doesn't work as well. Really, our patients tolerate this quite well. An hour in the office, unfortunately, at a doctor's office for almost any reason is pretty normal. To check in, do paperwork, get dilated, or if you're getting your foot looked at because you hurt it, to go get a foot x-ray and come back and have the person look at the x-ray. it's not really a huge amount of time. I would be very hesitant to do something that didn't have as good of results in order to save 20 minutes. All right, any questions about crosslinking? I have a video about crosslinking, but I'm going to talk a little bit about Intacs first, it looks like. So I mentioned some of this before. Intacs originally developed as a reversible treatment for low myopia, low amounts of nearsightedness. They can typically improve the keratometry by around 2 diopters. So that's if you take a normal cornea and you put this Intact in, and you will see the cornea flatten out a little bit. There's an additional benefit in keratoconus because you're not just trying to flatten out a normal cornea, you're trying to get the bulge flatter, and if possible, shift it from an off-center spot into the middle, because the bulge in the middle it's going to be shaped more like a normal eye. So approved on a compassionate use exemption. I think I've already said all of this. Topography must be analyzed by cornea gen, must be treated, and the thickness. All right. Somehow I got a duplicate slide. So Intacs should typically be performed prior to cornea crosslinking. If you're going to make the shape better and then lock it into place, well, I mean, yeah, you should make the shape better and then lock it into place, not lock the cornea into place and then try to reshape it afterwards with an implant. All right, so I have a movie of Intacs. So there's 2 movies actually. Let's see if it starts automatically. Looks like it doesn't. So this is the LensX laser. We use this for cataract surgery, for LASIK, for Intacs, for camera inlays. So the patient is laying down here. A little suction ring attaches to the patient's eye. We can see what's happening on the screen. This is a live OCT of the front of the eye. We haven't yet contacted the patient's eye, so this is going to be their cornea. It doesn't look like a cornea, but so it's going to cut two channels in the cornea, and it goes pretty quick. Oh, there's sound. So suction goes on, you'll see the meniscus kind of pop out here. And then I need to make sure it's centered on the pupil, which it's pretty centered already, but I move it over just a little bit. And then the treatment's going to be less than 20 seconds.
You're going to hear a little buzzing sound. Things might get just a tiny bit fuzzy. Very nice.
So this is the... And then this is an incision. Well, you can't see it now. An incision that's made to access these channels. So this is a partial thickness tunnel in the cornea. So then we move the patient over to a different microscope, clean off the eye, put a little eyelid holder in, a drape, and then we've got the 2 little plastic segments that are going to be implanted into the channel that's pre-cut. Looks like this is a 3-minute video. So holding this little plastic ring, I need to put it into the incision, and it's a very tight fit. You want it to be a tight fit so that it'll help stretch the cornea into a better shape. So with this treatment, the eye is numb. You know, they have a numbing drop in. It's quite comfortable for the patient. Yeah. It's quite comfortable to have somebody jam a piece of plastic into your eye. Right. And then once this is in, you can't feel it. It's under the surface. It's not all the way inside the eye. It's not on the surface of the eye, so you don't feel it when you blink or anything like that. So I just need to push it so that it's not right at the edge of the incision, which I've done. And they're sized so that they don't touch each other. They don't go 360 degrees around. They go most of the way around, but they don't touch each other at the far end.
Why? What's the purpose of not touching?
Oh, I don't know. Maybe they could cause some problem with their position, or I don't know. But they don't touch. They didn't make them big enough to touch. So they're little tiny things that cost a lot of money. So I guess I'm being very careful picking it up on the back table off the video screen here. so that I don't drop it on the floor, because that wouldn't be good.
What kind of incident is there of like them moving out of position once they're at night?
They don't move. They're tucked into a nice tight tunnel. They are very easy to remove. There's a little tiny dot you can see here and here, which is a little hole in the intact, and it's very easy to put an instrument in and grab it by that hole and just pull it out. So they're very easy to remove if for some reason they need to be removed. Theoretically, I've heard they can turn in the channel, but I'm pushing really hard to get it to move. It's not. I've never seen that. It's not going to move just by the person blinking or jumping up and down on a trampoline. And that's basically it. So stitches are not needed. The incision is teeny tiny and seals itself. Before I put these implants in, we put antibiotic drops on them so that some antibiotic goes into the channel with the Intacs. And then you take an antibiotic steroid combo drop afterwards. Okay, so Intacs. And you don't need a shield. I mean, patient can see, they can walk out seeing. You didn't do anything to the center of the vision, and there's no reason a person can't see that same day. So, any questions about Intacs so far? I've never had to remove one. Yeah, I've never had to remove one.
And they're at 7, so they're not in the way of like the visual access when you're trying to do like cataract surgery.
Right, so I've done 3 cataract surgeries on patients that had Intacs in place, and they're not really in the way at all. So they don't interfere with any of the testing. Really, the 7 millimeters, that's bigger. Our average intraocular lens for cataract surgery is 6 millimeters. So, and LASIK, the average optical zone is 6 millimeters. So this is actually bigger optical zone than those treatments, which are tolerated really well for glare, things like that.
Do you use the same calculations then that you would use for LASIK patients?
No. It's been a long time since I've calculated one. It's been almost 10 years since I've done one. But the issue with the LASIK calculations is LASIK reshapes the front surface of the cornea, but not the back surface of the cornea. And so it interferes with some of the mathematical assumptions in the formula, and that's why you have to change things. So a couple things about this. One is it's changing the shape of the front and the back surface of the cornea, so those assumptions hold more true. But you probably can just ignore the fact that the Intacs are in there when doing cataract surgery. You actually have more of a problem with a keratoconus patient that is untreated and has a really irregular cornea. Those patients are much harder to get an accurate lens implant in. The closer to a normal shape you get the cornea, then the better the normal intraocular lens formulas will work for getting you the refractive result you want. So basically, the formulas right now, they assume if somebody has a really steep cornea, there's certain things about the shape of their eye and the shape of the anterior chamber, and it's just not true with keratoconus all the time. So. All right, so cross-linking, as we talked about, this video is kind of an accelerated video. Patient comes in, they get numbing medication, relaxing medicine, they're comfortable. So step 1 is to have a little eyelid holder in and to make an abrasion on the central 7 millimeters of the cornea. It's easy to see where that is because the Intacs are there. This is a patient, he had an Intact actually put in maybe 4 or 5 years ago, and before cross-linking was FDA approved, and now we're able to go back and do cross-linking because he continued to progress with just the Intact in place. So
Did you send them home with like a bandage contact lens or something, or they just hurt?
Yes, I send them home with a bandage contact lens, for sure.
So it's a basic similar pain level to a super K?
Super K, pterygium, PRK is all going to have similar. So these patients have normal epithelium usually, so it's actually difficult to give them an abrasion. I'm working really hard to give people an abrasion. Anyways. So the machine has a timer on it, which you can't see, but the timer is going to count down every 2 minutes so we can put a drop of yellow medication in his eye, the riboflavin. At the end of the half an hour, we check the thickness of his cornea to make sure that it's 400 microns. And then the iPhone doesn't pick up the ultraviolet light on its camera, go figure. But there's a little green light that's going to be shining right on his cornea. You can't see it. All you can see is the red aiming beam. So you adjust this over the eye. And then there's actually a remote control. So if he moves his eye around a little bit, you just move the remote control and it follows his eye around. So there's a bandage contact lens that I've already put in, and this is a frozen block of BSS on a WEC. And basically it's just like if you sprained your ankle, if you iced it, if you give a little cold treatment on the surface of the eye, they're going to feel better afterwards. And the contact lens is there to make sure that the eyelid's not rubbing against the eye over and over again. Give them a drop of antibiotic, anti-inflammatory, including a non-steroidal, which is helpful for pain. And take out the eyelid holder and clean him up so he doesn't have to go home with a yellow eye. So it takes about an hour. That was nice to see it all in 2 minutes, but yeah, question?
Is there a reason why you use the spatula instead of like a brush?
Just because I don't have a brush here. And I have the brush next door. I could borrow it, but yeah, that's something I've every time I'm doing that, I think, should I do something different to speed this up? But I mean, it takes 30 seconds. So, any other questions so far? So, what to expect post-operatively cross-linking, and can cross-linking be repeated are two questions that were submitted to me ahead of time. So, to expect after the treatment, it's just like any other treatment that causes an abrasion. There's going to be some discomfort. We do some things to try to help with that, like the contact lens, drops, ice, oral pain medication. Abrasions typically heal in anywhere between 3 and 5 days, and then people feel better. Their vision's not instantly normal after the abrasion heals. Usually there's still some swelling, and the surface of the eye needs to smooth out. And that's usually going to be pretty good, somewhere around 10 to 14 days. And then their cornea is going to start flattening, so their refraction is going to be changing, usually for the better, unless they happen to be a farsighted person with keratoconus, which is very, very unusual. Anyhow, so the refraction should be changing for the better. And it's always a tough thing to decide, okay, when should we change a person's glasses, because you don't want them to spend money over and over and over again on glasses that are changing. But certainly by a few months out, it's reasonable to do a refraction, and if they see better, to dispense that. Can cross-linking be repeated? The answer is yes. So, it takes time for things to get worse. So when you look at the Dresden protocol, I said earlier that 96% of people were stable at 3 years. Well, at 1 year, 100% of people are stable. I mean, at 2 years, 100% of people are stable. At 3 years, 4% of people have progressed. Well, maybe those 4% of people were probably progressing the whole time. It's just they were moving so slowly you couldn't tell that their cornea had changed. So if you see that things are worsening, you can repeat the treatment. I think not everyone, but some of the people that progress are going to be your patients that have other eye problems, such as bad allergies or blepharitis, where they're rubbing their eyes a lot, or they have some type of immune inflammatory disease that's causing things to get worse, as opposed to them not having any other eye problems and they're leaving their eyes alone and they're progressing. I think that's less common than somebody that's having other problems. But yes, it can be repeated. I think if you repeat it a second time and they're still getting worse after a second treatment, repeating it a third time probably doesn't make sense. And one common place where I think repeating would come in is if somebody has one of these accelerated protocols that doesn't stabilize people as often. I think that's one of the arguments for it, is they say, well, if they get worse, we can always go back later and do a full Dresden protocol where we remove the epithelium and do the full 30 minutes of the ultraviolet light. So personally, I wouldn't really want to go through it twice, but I'd rather just do it the right way the first time. Of course, people want to speed things up, so eventually, there's a good chance someone will come up with a medication that works as well as removing the epithelium, and they'll come up with a way of giving the light that works as well as giving it in 30 minutes to give it in 10 minutes. And I'm all for that when it gives equal results. So, but yes, it can be repeated. I believe this is the end of the talk, so I will definitely answer any questions that anybody has. Any questions? Yeah.
Eye drops develop, you can't really do this now, right?
So eye drops are something I didn't talk about, and actually, there's still some unknown about what causes that. So what eye drops is it's a tear in Descemet's membrane, so the inside layer of the cornea tears. We thought it was because the cornea was bulging so far forward, that membrane's only so stretchy, and eventually it stretches so much that it breaks open. And then the person develops a lot of edema in their cornea, which usually they end up with blisters on the surface of the eye, which can pop, and they can get scarring and neovascularization. So crosslinking, I don't think would work well when a person was having eye drops. So when a person was actively swollen, I don't think the ultraviolet light would penetrate very well and give good crosslinking. But after that has resolved, the person still has keratoconus, and you could do this treatment. Interestingly, one of the treatments, it just hasn't worked very well for eye drops, has been to inject an air bubble into the anterior chamber of the eye, because putting that air bubble in there, then the fluid can't get into the cornea. The problem is it doesn't last that long, and the tear is still there, and when the air goes away, then their cornea swells back up again. But recently there have been some articles published, and I haven't treated a patient for this because this information is so new. I haven't had the opportunity to, but they will do a DMEC, which is a partial cornea transplant. So when somebody's endothelium wears out, we transplant Descemet's membrane with endothelial cells, and there are reports that if somebody has eye drops, you can go in and put in a new inside layer of the cornea, and that's going to patch this gap, and then the edema will go down, and then you would probably want to cross-link them. So, one other thing I did not mention, but ultraviolet light kills living objects. If you get enough ultraviolet light, you're going to get skin cancer or a little more. You could sterilize things. You could sterilize water. So you have to be careful not to use too much ultraviolet light because you can kill your endothelium. But one use that's sort of being researched with crosslinking is using crosslinking to treat resistant corneal infections. So, somebody gets a little bacterial ulcer, usually you're going to treat that with an antibiotic, and in a day or two it's going to be doing really well. You don't need to resort to a surgical procedure. But if somebody has a really bad infection, like a fungal infection or acanthamoeba, that's going to take a year to clear, that there's promise that using this type of treatment and basically exposing the full thickness of the person's cornea to ultraviolet light is going to kill off a lot of those organisms. So that's something that's not FDA approved currently, but is a topic of research. So you may see that happening down the road a little ways. All right, that's all I can think of for today. Thank you everyone for coming out. Yeah.
We're just talking about treating like the acanthamoeba and stuff like that. So is there anything you always hesitant to do and really worry about what you're going to do? Someone has like a neurotrophic cornea, or is that there? What kind of a possibility is there of damaging that?
Right. So, neurotrophic corneas, usually there's a disease that's caused the person to lose sensation on the surface of the eye. The most common one would be shingles or herpes simplex virus. So most herpes simplex virus can happen at any age. Shingles more commonly happens in older people. Those two diseases don't overlap very much in this condition. Most people with keratoconus haven't lived long enough to have shingles. So Yeah, I think if you knew somebody had neurotrophic cornea or other difficulties with healing, severe diabetes, something like that, that'd be a reason to hesitate to do this treatment. But thankfully that doesn't come up very often. It's not that common. All right. I'll stick around for a while to answer any questions that people have, but thank you very much.